Imagine that everything about your health, every test, every symptom, every whispered conversation with a doctor is written down in a colossal digital secret recipe book. This book is the official guide to you. It holds a recipe to how they cook your care. For most of history, this book has been kept behind a locked vault. Only the people in white coats, the head chefs, the assistant chefs, had access. You, the patient, were a mystery to yourself, only receiving filtered summaries of your own health story. But that's over. A powerful federal law, the 21st Century Cares Act, went into effect and it fundamentally changed the power structure. This law gave you something truly amazing. Before I go on, if you're watching this right now, I encourage you to subscribe to this channel if you haven't subscribed to this channel yet. I have many things coming to you about your own health, about navigating the healthcare system, and about your own data, your own medical record. So here we go. The master key to the entire secret recipe book, and that's you, that's yours. This means that legally, your medical organization must give you access to your electronic health records, all the clinical notes, all the test results, the medication lists, for free and without delay. So you now have the power to read the full, unedited, written story about you. And with that master key comes the first, most critical piece of insight we are sharing today. You cannot trust that your secret recipe book is perfectly written. In fact, don't ever assume that your recipe book is perfectly written. You should actually assume that it has some serious errors in it. You are now in charge of your own care, and your job is vital. And it's vital to your safety, and it's vital to the safety of your loved ones. All right, so first of all, I want you to think about a Hyperspeed kitchen. Let's talk about the mess. Let's talk about what's going on. This is why the recipe book is wrong. It's not because healthcare staff are bad people. It's because they're working in a hyper-speed kitchen, right? You've heard the saying, if you can't take the heat, get out of the kitchen. Well, this kitchen is not only hot, but it is really fast. There's a lot of pressure. There's a lot of pressure to do things well, to do things quickly. There are a lot of cooks in the kitchen. There are a lot of voices, and there are a lot of people with needs out there waiting to be served in the dining room. And it's not just you. There's pressure every single minute of the day. The pressure to move fast means that they're consistently taking technical shortcuts just to keep up with the overwhelming volume of patients. Because right now, everyone is tasked with doing more with less. We already know what's going on with healthcare, especially in this country. Folks are having to make decisions. And folks are having to sink and swim. And a lot of those people who have to sink or swim aren't just you, aren't just the patients. They're also the people caring for you. Pull back the curtain and look at the quantified factual chaos in this kitchen. When researchers gave patients their master keys and asked them to read their own records, and this gets scary, the findings were quite shocking. But not surprising to me, I'm not gonna lie. 1 out of every 5 patients who looked at their files reported finding a mistake. And this is the patient. This is you. Imagine you going into your own health records and being able to pick out mistakes. They're actually verified mistakes. Those mistakes were obvious in layman's terms and not just through medical jargon. So I want you to think about that number again. 20%, right? 1 in 5 is 20%. 20% of your records are carrying flaws that you can actually spot. Makes me wonder what's there that you can't spot. If you look at your 5 closest friends, think about this, y'all. Or if you live in a household with 5 people in it, one of them has an error in their official health story right now that they could spot. That means relying solely on the doctor to spot the mistake is nonsensical, because providers do not have time to go into your chart and audit it and correct things in your chart. So these aren't just little typos, y'all. These are major, potentially life-threatening flaws. So among the patients who found a mistake in their chart, a huge percentage, which is 4 out of every 10 people, felt that the mistakes, so those who saw mistakes, 4 out of 10 people felt that the mistake was serious. And what does a serious mistake look like in your recipe book? Let's see. It could be a mistake in your diagnosis, leading to the wrong treatment plan. It can be an error in your medication list where a wrong dosage is written down. I've seen that. Actually, the unfortunate thing is I have seen all of these things. Ask any healthcare professional that uses the electronic health record on a regular basis. Ask them. You might have one watching this with you right now. It might be you watching this right now. Ask yourself how common this is. It could be missing or incorrect information about your allergies, meaning the head chef might use a dangerous ingredient in your recipe. The pressure of the Hyperspeed kitchen means the system is built with flaws that injure millions of people every year. Let me say that again. Millions of people are injured every single year because of flaws that could be the result of what's cooked up in the Hyperspeed kitchen. So this is why your job as the head chef is not a luxury. It is actually a clinical and safety-based necessity. So let's talk about the digital trail derailment. So how do these mistakes happen? They happen because the healthcare system is full of terrible people. Terrible, no good, very bad people. No, I'm joking. I already told you that. That's not the case. They happen because the healthcare system depends on a digital train, and that is the electronic health record system. The train is supposed to be strong, it's supposed to be safe, but it often derails due to technical and procedural flaws. The problems aren't just about human fatigue. Human fatigue is definitely a big part of it, but it's not just about human fatigue. They are about flaws built into the technology and the way that staff interacts with it. Because honestly, with a lot of this technology, the human using the technology, those folks who are boots on the ground, front lines, using this technology all the time, they were an afterthought in the creation of a lot of this technology. And the proof is truly in the pudding, I'm not gonna lie. So when experts analyze common EHR risks or electronic health record risks, they found 4 types of technical chaos that directly led to errors. I'm gonna go further into this in the next video. But 1 is the wrong name tag. Patient confusion, y'all. This is where the digital train accidentally pulls up the wrong file. A doctor, a nurse, somebody rushing enters a note or an order into a record that actually belongs to another patient. This happens all the time. And when I say all the time, I mean all the time. This is one of the most frightening kind of errors, as it instantly contaminates your health story with someone else's diagnosis or family history. If you read a note about a medication that you've never heard of or a surgery that you've never had, the wrong name tag is the culprit. Literally, records or have had lab results faxed over to me and found out that my lab results were faxed over to someone else. I didn't realize this was the case. I looked because, of course, you assume that when you get results faxed over to you, but they're yours. You know, it was through my own personal digital virtual fax machine or fax line, right? I go in there, I look at it, and I'm just like, oh my gosh, my kidneys, I'm worried, I'm freaking out. I go up to one of the providers that I was working with at the time, and I'm just like, nephrologist. Went up to one of the nephrologists, and I'm just like, oh my gosh, am I in acute kidney failure? What is going on? And then he looks up at me, starts laughing, and he's like, who is this? This isn't you. Points to the name. It was not my name. I ended up calling the place that I got my lab draws at, because this was not the hospital. I did not go to the hospital for the labs because I was on a budget. And it turns out that they did a oopsie swapsy. And actually my provider ended up getting the wrong lab result as well. And so that really, really slowed down my workup for my condition that I actually had. Not acute kidney failure, but I did have something going on at that time. But that just goes to show, like, there is a lot that goes on. I'm one of those people that whenever there's a test or procedure or anything like that, I like to have my own personal copy. I don't necessarily trust that all of my information will end up in the electronic health record. And so that's just how that happened. It happens all the time. I have seen it happen a million times. So let's talk about the broken telephone. So data transfer issues. Your data must constantly jump between different systems. That is one of the reasons why HIPAA is actually a thing. I'll do a video on HIPAA for you guys. But your information needs to be able to move from one organization or one entity to another, and it needs to do that fast. It has to do that fast. That's why we don't live in a country full of paper charts anymore. Thank you, 1996. This is digital now. So, and this data, there are different types of data, but it's health data, and it jumps between systems all the time. It's supposed to. It's supposed to be accessible to whomever is taking care of you. Of course, if you give them permission. So this is from lab testing to the imaging center to your primary care doctor. And if the connection breaks, like think of a bad Wi-Fi signal, or think of the data getting corrupted. If the data gets corrupted, this is the broken telephone of the digital age, and it accounts for a very, very significant chunk of errors. The full truth of your test results never makes it to the head chef, who really needs to read it. If a whole chunk of your information is missing, it's like having whole ingredients missing. You're supposed to make potato soup. Ooh, that sounds good. You're supposed to make potato soup, and the potato soup calls for X number of potatoes and salt and pepper and cream of tartar, but you don't have any potatoes. That chef isn't going to be able to make potato soup. They might be able to make you some tomato soup or some other type of soup. They might be able to make do with what they have, right? Or they might delay your dinner to go out and get some potatoes for you, which would be, in this scenario, it would be testing you again, or sourcing that information, sourcing that data again. But it causes delays, and time is of the essence when it comes to healthcare. Now let's move on to typos. Wrong data input. The basic human error of typing fast. Writing hyper when you meant to write hypo. I'll give more of an example of that in the next video. Or transcribing a complex medication order incorrectly. This is huge. When I say this is huge, this is huge. To the point where days of old, nurses like myself used to take orders from providers on the phone. More and more, we're finding that organizations, especially led by, the charge has been led by teaching institutions primarily, they're going away from telephone or receiving telephone orders. Nurses don't receive telephone orders as much. You might get a verbal order in the emergency department or the ICU when timing is really acute, but you will start to find, I've spoken with some of my colleagues about this, even then, you would be pretty hard pressed to find where an order is put in by someone other than the provider or the scribe. And that is because we want the integrity of that order, of that intervention, to be commemorated properly. We need to be able to see the chain of custody. We need to see who ordered it, and they need to be able to produce a rationale, which it's really hard to do that when you're playing telephone. And we already know the game of telephone. So the simple output mistakes have massive risks. The reason that we don't do telephone orders as much as we used to anymore with providers is because those telephone orders, just like a game of telephone, led to mistakes, led to transmission mistakes. So they're also often the source of zombie facts, and we will definitely talk about that coming up. So the electronic health record is central to your care, and in fact, when diagnostic errors occur, and that means a missed diagnosis or a delayed diagnosis, the EHR system, or the electronic health record, is cited as a contributor of over half of those cases. It's attributed more than 50% of the time. Those cases are attributed to the electronic health record that I'm talking about, the one that you are head honcho over now. So this proves that the system is not just recording chaos, it is actually contributing to it. So the single greatest source of error in the factory floor is the copy and paste shortcut. And let me tell you something. When it comes to operations, copy and paste can be your best friend. Copy and paste can be your worst enemy. And to be honest with you, when it comes to documentation, and in those places where I've seen copy and paste happen all the time, and copy and paste taking place as part of a workflow, it's typically not part of the official way of doing things. But when crisis strikes, when time is short, when resources are short, when providers, and I'm not just talking about doctors here, healthcare professionals get closer and closer to burnout, or maybe they are already burnt out, copy and paste comes out, and it comes out in force. So to save time, providers write one detailed section, like your long past medical history, and then hit copy and paste, and that entire block of text goes into every new visit note that they write about you half the time. Don't take my word for it. Please, I encourage you. You have access to your medical records right now. If you have a patient portal or whatever, first of all, if there's a patient portal available to you, please opt in so you at least know that you can get in there. Save that username and password somewhere where you're going to remember it, whatever. But you need to have access to this. This is very, very, very important because this is what runs your care. Have access to that medical record. If you do not have a way of getting to it digitally, then pick up the phone or put on your business heels, roll up, and request a copy of your medical records. Take yourself a nice little highlighter, or this is a red marker, and have fun. Sit back, relax, drink a cup of coffee one morning, and instead of reading the comics on Sunday morning, read that medical record. Go through it. At least, you don't have to go through the whole thing at one time, but I recommend at least looking at your history and physical. Do that first and foremost. Anyway, so yes, the prevalence is absolutely rampant. Between 66 and 90% of clinicians routinely use copy and paste in their documentation. That is clearly the majority. You hear that? It is the crunch of the Hyperspeed kitchen that that cannot function any other way, unfortunately, with the way that billing is going and coding is going and the amount of patients that folks have to see. It really just becomes a necessity, unfortunately, in a lot of settings. But this shortcut creates two profound, very long-term dangers for your health narrative. One is the note bloat, the sticky note mess. The first result is note bloat. That is when your file becomes impossibly long and repetitive and really, really boring. You look at the book, it's like a book where the same chapter is printed 50 times in a row. Like, I'm telling you, it gets annoying. So when you're going through, remember what I told you about that Sunday morning, when you're going through your health record, go ahead and do it. Like, go ahead and box off the first time that you see a note, and then you can even make a tally mark next to it every single time you see that exact paragraph, that exact chunk replicated in your record. Just saying that. So there you go. So when a new head chef, actually you're the head chef, but when a new assistant chef opens your record, they are faced with thousands of pages of text. This is not a joke. I have faxed over and have been the fax recipient of many a chart. Let me tell you, those things are hefty, okay? And the vast majority of that is old, decrepit, crusty, out-of-date, irrelevant, old data. And this massive pile of duplicated text hides the one tiny, new, and critical piece of information that they need to spot. It's like trying to find a needle in a haystack. Like, that is how difficult it is. Everything out there is just in black and white text. Half of this stuff is copied. You have to try to suss out where the repetition ends and where the newness begins. And then even then, you still have to dig, like, where's Waldo, all up in that chart. It is not easy. So know that your critical information, the information that pertains to what's going on with you right now, is drowning in all of that other data that is out of context. So this massive pile of duplicated text hides the one tiny new critical piece of information that they need to spot, and it dramatically increases the chances that they will miss a new symptom or a critical update. Next, let's talk about zombie facts or error propagation. The zombie fact is an error, a typo, an outdated piece of information. Remember what I said about the volume of outdated information in your chart that is copied and pasted so many times that it becomes immortal in your record and it simply refuses to die. It's like that immortal temporary diagnosis that you got way back when. Like, you had tonsillitis when you were 10 years old. That thing still says you have tonsillitis in your active problem list. You see what I'm saying? So imagine a doctor once typed that you were allergic to a certain type of dye during a minor procedure 6 years ago. You corrected the doctor and you're like, actually, nah, that was just fine. But they forgot to fix the original note. So if 30 subsequent doctors use copy and paste, that incorrect allergy is now cloned 30 different notes in your chart. It becomes what we call a zombie fact that is impossible to kill and forever influencing what tests and procedures you can actually receive. Yes, this happens all the time. Let's quantify it. We know that this is not just an inconvenience. Research has shown that the high prevalence of copied and pasted text is significantly linked to the 14-day readmission rate. Let's just say to readmissions. Patients end up visiting the hospital because of documentation. Because the documentation was copied and pasted. Let that sink in. So this is a factual, data-driven link. Sloppy documentation caused by copy and paste shortcut leads to patients getting sicker and returning to the hospital sooner. The shortcut, meant to save a doctor 30 seconds, can put your health at risk for months, if you're lucky, but years. You might be the one who audits the file for those repeating immortalized errors. And unfortunately, the onus, since the CARES Act, thank goodness for the CARES Act, but that onus falls on you. I know it's them doing the driving of the documentation, but the onus of that chart, that electronic health record, falls on you. The consequences fall on you. So our final deep dive on the factory floor of chaos focuses on the autofill template. I will touch more on this in the next video, but this is the robot who loves to tell lies. The robot lie happens when the electronic health system is trying to save the provider time. Whoever is documenting in there is trying to save them time, because we know that providers and healthcare professionals, the last thing that we want to do is sit at the computer and chart all day. We went through hell and back. We went through orientation and preceptorship and shadowing and clinicals, all of that. We went through all of that to take care of you, not to take care of the computer and not to take care of the chart. We went through all of that to take care of you, right? And so to save the caretaker's time, robot lies happen, because guess what? The companies want it to be easier for us, so they make it possible for things to be auto-filled into the chart. Like we call it within normal limits, WNL. So if the doctor clicks on a routine assessment, the robot automatically fills in a boilerplate text like all extremities are normal, pulses are equal, abdomen non-distended, non-tender, so on and so forth. So like the normal assessment findings that one would expect to find. This is where the system's rigidity clashes with reality. Because chances are, if you are unwell and you're needing to see a doctor because you're unwell, obviously we want to receive medical care for maintenance, for prevention, and all of that. That's what we want, right? But if you are seeing it because you have a problem or an issue, chances are all of those assessment findings are not going to be within normal limits, right? So the robot can write an impossible lie that the provider rushing to get to the next patient simply signs off on it without reading carefully. And this is human nature. I do not expect my providers to go back and reread everything before hitting submit. I really don't. Like, I know that would be considered best practice, like to review what you documented. But time really is of the essence, and we really have to be realistic. We have to get realistic about the circumstances that folks are working under, the situations that folks are under, and we need to get realistic fast, especially when it comes to maternal care, with a lot of these maternity wards shutting down, a lot of these hospitals shutting down. And I am holding some in my mind right now. I know of a few that are shutting down right now. Where are those patients going to go? They're going to be displaced into other places, and providers are going to continue to feel the heat of the kitchen, feel the pressure of the need that patients have. Patients are going to get sicker because it's going to be harder for them to access care. And then quality is going to fall by the wayside. I know that because I love quality. I'm a clinical quality person. So anyway, here's an example. One of my favorite examples is what happened back when I did nephrology. I had a double amputee leg, double amputee, and actually I had quite a few, because with certain diagnoses, amputation is quite common. So it was very clear to me. I knew what I was looking for in the chart. But when the history and physical and reviewing this chart, I'm reviewing a chart for a patient. I look in there and it says, pedal pulses palpable, which means pedal is feet. Pulses on the feet. I can feel them. Palpable means you can palpate them. You can feel them. Feel what? You're feeling air. That patient was a double amputee. They physically did not have pedal pulses because they physically did not have feet. That is one example. And that robot lie was perpetuated time and time again, just copied and pasted. Nobody caught it. How outlandish and how outrageous it was that a patient without pedal pulses, without feet, had normal pedal pulses. You know what I mean? And this sort of thing kind of gets to me, and I am going to get on my high horse a little bit here, because unfortunately, with a lot of these patients, and in this patient population in particular, I'm not talking about maternal health, I'm talking about another specialty that I used to do. Those patients really would benefit from thorough assessments. They really would have benefited from thorough assessments. It makes me wonder, to be honest with you, like, would this patient have pedal pulses today if their pedal pulses were assessed yesterday? Do you get me? Would they have pedal pulses today if they were assessed yesterday? In nursing, we have this phrase. The phrase is, if it ain't charted, it ain't done. We say, if it ain't charted, it ain't done. So there is no evidence anywhere else. Like, the evidence is in the electronic health record. That is where the evidence is. Whenever an intervention is done, it is documented. And the quality of that intervention is also documented. So there should be no question. That's the way that it's supposed to be in an ideal world, right? Go on and say that, oh, I'm sure that the provider assessed the pedal pulses on this patient before they became a double amputee. I'm not going to go on and say that because I can't. They didn't document that. In fact, they documented that those pedal pulses were normal. There have been a million times when, and I thought that for the longest time, I honestly thought it was me for a little bit when I was a new nurse at the bedside, coming a little bit early, and I would look at the assessments of my patients to kind of get to know them, to get an idea of what I was dealing with. And there were so many times, man, that my patients had miraculous healing occur, or the opposite, right? My patients miraculously declined. But that was because I was documenting my assessment, and I dared to question how well those assessments were documented by others. So seeing a major change, that's my dog, seeing a major change in clinical presentation, or not even clinical presentation, like in the documentation, seeing a major change in the documentation from nurse to nurse or practitioner to practitioner, I also take that with a grain of salt. And unfortunately, we do have to take that with a grain of salt because we are limited to what we can see in the electronic health record. But yeah, that robot lie becomes the source of truth. And just like I was a person that received a lot of pushback from being honest about my assessments and documentation, how I did that, just as I faced scrutiny and lots of questions because everybody else charted that the pedal pulses were palpable, but you, rogue agent, didn't. Take it with a grain of salt. I'm telling you, that medical record that you have, read what it says and read what it doesn't say. read the human element as well in there. Yeah, that's all I'm going to say about that. So this failure does create a profound problem for the patient, and it results in tunnel vision. So tunnel vision, let me define it. Tunnel vision is when the templates encourage the provider to look for only a few things on the list. If your actual problem is complex, like a lot of problems are, last time I checked, all of our systems, our health systems, were linked together, right? So like you having joint pain or subtle mental health issue, there isn't a standard box in the robot checklist. The provider has to sign off on normal, even if you provided significant issue just moments earlier. That is an issue with the templates that we have available to us. That is an issue with the electronic health records. A lot of times the context that you actually need will be in what we call an unstructured data field. And that sucks. Just like back in the day, I'm going to date myself here, but back in the day, I'll say it. So back in the day, you might get pages, or you might send a page to no one in particular by accident. If you work in a place where they have a lot of print, like in a large organization, a huge building, maybe a hospital, right? A lot of times the default printer might go to Timbuktu. We call it the document graveyard. At least I call it that. I want it to catch on, I really do, but it hasn't yet. That is what the unstructured data fields are like. It is actual hell in those places. And I promise you, as little context and as hard as it is for you to understand it, it is just as hard, if not harder, for medical professionals, healthcare professionals, to really understand the data that is in the elephant graveyard of your electronic health record, if that makes sense. So the documentation becomes less about the nuanced truth of you and more about satisfying technical requirements of the computer. You must be the one who points out that the robot lied. All right. So we spent some time pulling back the curtain on the kitchen nightmare, the elephant graveyard, all of that. We have seen the chaos is not driven by malice necessarily, right? It isn't. Well, in some cases it is. But I honestly think, just because I am the person that I am, that those cases are few and far between. But by the systemic pressure to take shortcuts or to just use the technology at our disposal as best we can, the zombie fact shortcut, the copy and paste, the robot lie with the autofill, our charts have issues with it. Houston, we have a problem. We have quantified the risk. 1 in 5 records are wrong visibly by the patient. It makes me wonder about records that the patient doesn't pick up on automatically. Like maybe the patient fell asleep while they were reading their chart, wasn't able to see the rest of the chart. But that inaccuracy is tied directly to safety and the quality of your care. If you feel like your care team is spinning wheels and not able to get to a diagnosis, don't automatically assume that the issue is with your provider, is what I'm trying to say here. We have to consider technology, but we also have to consider the circumstances that provider, that those healthcare folks, the people that are charting and documenting in our electronic health record, we have to consider what the pressures that they're under. And we have to acknowledge that a lot of these electronic health records are not designed for our use cases. Let's just say it that way. They're not. So I'll do that in another video. But the shift, that CARES Act, and the master key access is a powerful gift. But it is also a silent delegation of responsibility. The system needs you, the chef, I call you chief auditor. You're the final line of defense against errors that can be life-altering. And here I have an immediate action plan for you. So first of all, what I want you to do is get your pen, but I have homework for you. So first and foremost, this is what I want you to do. First, I want you to access your patient portal or your health record as soon as possible. And when I'm saying as soon as possible, ideally it would be today. But I will give you 3 business days. I'll give you 3 business days. If you are able to access your health record, put a 1 in the chat or say something to me in the chat, in the comments below this video. I really hope that you go in there and that you open it up. Now the next thing I want you to do after accessing your health record is I want you to go on a zombie hunt. I don't like zombie movies, okay? But in this case, zombies are real. And when you're dealing with a real threat, which zombies in your chart are definitely a threat. When you're dealing with a real threat, sometimes you gotta be aggressive, be aggressive. Look for those long repeated paragraphs. Find those old allergies that are outdated or those diagnoses that have nothing to do with you that keep coming back. Find them, mark them down. You should have a red marker too. I need to drop ship you guys some red markers. I want you to hunt down those zombies. I also want you to spot those robot lies. Look for impossible statements about your body or your current status that you and I and all of us know are not true. Look for them. See that? See that? Mark it out. Okay. In our next episode, we will continue our journey behind the curtain. We will decode the chef's secret code. We'll analyze the subjective and judgmental language that a lot of providers write about us. And we will learn about the sticky labels that kind of give us a bad reputation and that can permanently affect how future providers treat us. So thank you so much for watching. And remember to be active, be vigilant, and protect your secret recipe book, our care access. And as someone who has worked on both sides of the curtain, navigating the care system for myself and loved ones, lessons learned, I want everyone to benefit from what I have learned. I want everyone to benefit. So to help make this more discoverable, please consider subscribing. So I will catch you guys on the other side. Thank you and have a good day.
Look out for new updates.